the Symposia, Dr. Manas Kumar Panigrahi, is he with us? And Miki Fujimura? Probably they will come later, yeah. But all the speakers are with us. So then it's my pleasure to start our WFNS Education Symposium number 12 on the management of brain metastases. And this is a hot topic because there are some game changers, I guess. And we will start our symposia with Dr. Suresh Mukherji from United States on the diagnostic problems of brain metastases. Yes, Dr. Suresh.
Great. Can you see my slides and can you hear me?
Yes, very well.
Wonderful. Thank you very much for the opportunity to be here, and greetings from the United States. As everyone knows, we're about to go through an election right now, so it's a very unique time in the United States. So but again, it's a real pleasure to be here. Just one housekeeping for me. I'll have to leave in about 45 minutes. I have to give another talk at 10 a.m. my time. I don't usually do this on Saturday mornings, but it's just strange coincidence. So I guess if there are any questions for me, Dr. Mehmet, would you like me to answer them after my talk then? Would that be okay? Hopefully.
Yeah, that should be fine.
Okay, great. Okay, so I'm a neuroradiologist. I predominantly do a lot of head and neck radiology and skull-based imaging, and these are my various appointments both within the United States and outside of the United States. And again, thank you very much for the honor of the invitation. So what I'm going to be talking about are brain metastases, and it's a very interesting topic because as I was preparing for this talk, it's really unclear to me how many people actually develop brain metastases. And based on the stage of the tumor and also the type of the tumor, I've come across anywhere from 10% to 40% of patients have brain metastases. And sometimes, and oftentimes they are clinically occult. So part of that is pathologic data. But having said that, that is why it is important to evaluate patients for brain metastases, because we know the poor prognosis that's associated with patients that have this type of extension. So when we look at brain metastases, I think we're all pretty familiar about the imaging findings. They're typically enhancing masses. Oftentimes they're round, but they don't necessarily need to be. They tend to arise at the gray-white junction and the watershed regions. And part of this is because of the smaller arterioles. And also the farther they are from the feeding vessels, the less push, if you will, there is. So that's why they tend to deposit at the gray-white junction, the watershed region. We know that they can be single or multiple. They're oftentimes associated with this edema. And also brain metastases can be associated with different forms. You can have bone lesions, but also in this patient with adult medulloblastoma, this nicely demonstrates the leptomeningeal metastases that we can see in brain metastases. So this is just an example here of a deposit at the gray-white junction associated with the vasogenic edema. So these are all the typical spectrum, if you will, between this slide and this slide of the various imaging findings of brain metastases. Now, I hate to say this, I was born in the last century and I trained in the last century, and I was actually trained in the Harvard system, and I was at the Brigham and Women's Hospital. First time we ever gave gadolinium on a brain MRI. And the reason why I mention that is that ever since those days, over 40 years ago, we've still been struggling about ways that we can separate primary tumors from solitary metastases. And that is still going on even now in 2024. So what I'll do is I'll go over the different types of metastases and talk about some ways that you can help identify metastases and separate these from metastases mimics. So on the top here, this is just a classical example of metastases I mentioned before at the gray-white junction. And this is an example of glioblastoma multiforme. So when we see the GBMs, Metastases can be solid, they can be rim enhancing, but when we see something like this, which is a larger mass that has this very, very shaggy margin and has this solid component that's extending within the lesion, and also with the substantial vasogenic edema, certainly we think the possibility of glioblastoma. So I think this is a fairly dramatic case of a GBM. And in general, I don't think any of us would confuse a GBM from the solitary metastases that I show. But on the other hand, this is a patient that has lymphoma. So when we look at this patient that has lymphoma, if we look at the T2 weighted images, we can see a mass here involving the centrum semiovalle and periventricular white matter of the left frontal lobe, and this periventricular abnormality. And the contrast enhanced study shows multifocal lesions. So what are some ways that we can separate lymphoma from metastases? First of all, on the non-contrast CT, what we see is this area of more increased attenuation than we typically see in a metastases. And this is felt to be related to the hypercellularity of the lymphoma. Lymphoma also tends to involve the deep gray matter, specifically in the basal ganglia, and it also has a predilection to occur in the periventricular white matter. So from my standpoint, if I look at a CT scan and I see increased attenuation, and then I see enhancing masses located in the deep gray nuclei, or should say the basal ganglia and these various lentiform nuclei, and then also look at the periventricular white matter, then I start thinking about lymphoma. Now, this is an example of melanoma metastases. So when we look at melanoma metastases, as we know, they're hypervascular and they have a predilection to hemorrhage. So if I am looking at a lesion involving the brain and I'm trying to figure out whether it's a metastases or not, or specifically the type of metastases, if I look at the non-contrast CT and I see these areas of hemorrhage, then this suggests that this is a hypervascular lesion. We know various lesions can be hypervascular. I tend to use the mnemonic MATCH, which is melanoma, anaplastic lung, thyroid, choriocarcinoma, and hypernephroma. So those are my mnemonics for these hypervascular metastases. And when I see this frank hemorrhage, then that really leads me to the diagnosis of melanoma. On the non-contrast T1 weighted images, we can see the T1 shortening. This is likely either due to melanin or some type of methemoglobin. Methemoglobin typically has increased T1 signal. Here we can see the surrounding vasogenic edema. And in this case, in melanoma metastases, on the T1 weighted images, we see hemosiderin. Now, if we see hemosiderin, in this case of melanoma metastases, now we have to think, is this due to blood products from melanoma, or could it be due to another etiology, another pathology? And when we do think of blood products and hemosiderin, and if you will, what we refer to as blooming artifact, we always have to consider cavernoma. So this is an example of a cavernoma. So here we can see increased attenuation on CT, high T1 signal on the non-contrast T1 weighted image. These lesions tend not to enhance. And again, we can see this blooming on the gradient echo sequences. Why I would suggest that this is a cavernoma and this is a melanoma metastases is because of the surrounding vasogenic edema. Now, sometimes cavernomas can bleed and you can have the vasogenic edema, but in general, cavernomas are oftentimes incidental, whereas melanoma mets tend to have this vasogenic edema. Now, this is an example of multiple ring-enhancing lesions in the brain that have surrounding vasogenic edema. Here we see the nice ring-enhancing lesions, and this is a nice example of abscesses. So when we see something like this, we have to often ask our patients, are the patients febrile? And we know that abscesses in about 50% of the patients are afebrile. So sometimes that clinical history is not beneficial. So when we see these ring-enhancing lesions, they sort of have the typical appearance of an abscess, but as neurosurgeons and radiologists, I always say we don't get older, we get more experienced. And those of us that are more experienced, if you will, have seen metastases look exactly the same. So the challenge is how can you separate abscesses in afebrile patients from metastases? Well, one way that you can do this is to look at the ADC maps. And ADC maps are not 100% when we look at restricted diffusion. But in general, if we look at the abscesses, the amount of edema surrounding the mass tends to be greater than what I've seen in abscesses. It's hard to quantify this, but it's just something that has been reported and something that I've seen. So if it's something that I'm not sure about and I'm trying to differentiate, in my own mind's eye, I try to determine the surrounding vasogenic edema with this ring-enhancing mass. Abscesses have also been described to have decreased peripheral T2 signal and flare signal. So you can see this dark rim here. And then when we look at the ADC map, this is what we described as decreased ADC within the abscess. Now, when this was first described, it was felt to be pathognomonic. As with everything in life, nothing is 100%. And I've certainly seen metastases have decreased ADC. But on the other hand, if I am looking at something and I see a lot of surrounding vasogenic edema, I see this peripheral area of decreased T2 and flare signal, and then I look at the ADC map and I see diminished signal here, then I certainly consider the possibility that this, in fact, could be an abscess, and that needs to be further evaluated. Here's another example, not necessarily abscesses, but these are multiple septic emboli. Again, I've seen brain metastases look exactly the same. Again, in the afebrile patient, it's going to be oftentimes very difficult to differentiate. So we do have to rely on whether the patient has a known history of any type of tumor, whether the patient is febrile. And I think in something like this, I know we see this a lot in our practice. We have our tumor boards every Tuesday morning. If we see something like this, one thing that you can do besides trying to biopsy this is go ahead and work up the patient for any cardiac abnormalities. It doesn't take a lot to do a echocardiogram to see if they do have a ventriculoseptal defect. You also want to know if the patient has undergone any type of recent dental procedures, because patients that have dental procedures can often get showered with these various septic emboli. So nothing really specific when it comes to the imaging findings, but we always want to see if there's any relevant history that can push us to help separate septic emboli from multiple metastases. This is something that can be confusing. This is an example of acute multiple sclerosis. Again, if you look at this, it can look exactly like metastases. How can we make the differential diagnosis and the separation? Number one, when you do have this ring enhancement in multiple sclerosis, it has been described that the margin of the enhancement adjacent to the ventricle tends to be less enhancement than compared to the outer margin. So we can see the thick margin here, but a thinner margin along the medial side adjacent to the ventricle. So I know that's helped me in the past. When we look at the contrast enhanced study, again, very, very hard to differentiate. But in this particular case, we can see abnormal enhancement involving the left optic nerve. So if we do have someone that presents with some unusual symptoms and they tend to have something like optic neuritis, as is seen here, this can push us over and say that this is not a metastases, but rather this is a form of multiple sclerosis in a patient that presents with unilateral vision loss. And this is an example of something that can be confusing. This was Balo's concentric sclerosis. Sometimes the imaging findings can be difficult, the clinical history can be difficult. But again, here we see these incomplete margins of enhancement. And notice the location, they are along the periventricular white matter. So in metastases, we would expect to see a full rim of enhancement. Rather, we see the segmental peripheral enhancement. And again, this can tip us over that we're dealing with a demyelinating process as opposed to a tumor. Subacute infarcts can also mimic this. This is a small area of enhancement here involving the left frontal operculum. In this particular case, when we look at the ADC map, we can suggest a diagnosis of an infarct based on the increased DWI signal. And again, sometimes that history can be confusing. But again, this is where looking at all of the sequences on MR can be very helpful. Just to complete the differential diagnosis, because we do have a global audience, if you are coming from an endemic area, this is an example of cysticercosis, again, involving the gray-white junction. We can suggest cysticercosis here and also potentially tuberculosis because we can see the decreased T2 and flare signal. This is an example of a patient that has hydatid cysts. I know we have people from the Middle East. And I think if we see this, we probably won't confuse this with metastases, rather classic hydatid cyst. In the United States, we see a fair amount of sarcoidosis. In sarcoidosis, you oftentimes see this plaque-like enhancement, which is involved in the dura, and sometimes you can have this peel involvement. Now, this could easily be due to lymphoma or other type of leptomeningeal disease, but in this case, it was sarcoidosis. And this is an example of radiation necrosis. This patient had enucleation and underwent high-dose radiation. If you look at this, you're not really sure what it is. You have to include the possibility of metastases, but it's always important, if you do work closely with your radiation oncologist, to know exactly where that high-dose radiation field was. So we saw this and we knew it was a high dose field and we felt it was probably radiation necrosis. And then about a year later, unfortunately, this thing blew up and this was all radiation necrosis. So if you see something like this in a patient that has undergone some type of craniofacial resection and has undergone radiation therapy, please look at the high dose field when you partner with your radiation oncologist. We can use a variety of metabolic imaging studies. This is an example of spectroscopy. So in spectroscopy, something that I'm quite familiar with, just to give you a brief example, there's the choline, which is a marker of cell membrane turnover, which is located at 3.2. There's creatine, which is a store of high energy, which is 3.0. And then in the brain, we have NAA, which is this neuronal tissue. Normally, choline should be low, NAA should be high. So when we draw our arrow here, it should be upward pointing. But on the other hand, when you do have metastases or any type of aggressive tumor, because these tumors have rapid cellular turnover, this higher cellular membrane turnover in choline should be higher. And because it's replacing your normal neuronal tissue, your NAA should be lower. So when actually this arrow should be pointing downwards, and this is more indicative of recurrent tumor. So if you're trying to differentiate recurrent tumor from post-treatment changes, if you have this downward pointing spectroscopy, this is more suggestive of metastases as opposed to bland radiation changes. I'm sure all of you are familiar with perfusion imaging. This is an example of perfusion imaging. I don't have time to get into the details, but suffice it to say that the best marker for perfusion is going to be cerebral blood volume. So when we look at our blood volume here, we can see it's brighter. This indicates that this lesion has higher blood volume, and therefore it's more likely to be due to metastases. This, on the other hand, are radiation changes. We can see this mass here involving the periatrial region. And then when we look at the perfusion, we can see there's decreased perfusion. So this is more suggestive of radiation changes. So the last thing that I wanted to do is very quickly is to talk about some of the practical issues, because I think all of you are familiar with a lot of things I talked about, but I did want to mention a couple of things that are probably very variable, that things that keep me up at night. So what I mean by this is I know that about 10 to 40% of patients will have brain metastases, but it's very important that if you are either resecting patients with brain metastases or you're treating these with some type of non-surgical therapy, I want to emphasize the fact on how important technique is when you're evaluating not only preoperatively, but you're monitoring this. Realize that MR is better than CT for detecting metastases. Also, the ability to detect metastases depends on various factors that are oftentimes glossed over and they're not recognized. So realize when you are following up these patients, it's important that you image the patients on the same field strength magnet. Realize that a 3T magnet is going to give you better detection than a 1 Tesla magnet. So the patient's done on a 1 Tesla magnet, then they're done on a 3T magnet, and you see more metastases. That doesn't necessarily mean the patient's gotten worse. It's possible it wasn't detected on the 1 Tesla magnet. So it's important to have a consistent field strength. It's also important that your T1 weighted sequences are consistent. Realize that 3D gradient echo sequences are oftentimes sub-millimeter, whereas standard T1 weighted images are oftentimes 3 or 4 millimeters. So you're going to get better detection of the metastases when you do these stealth-like sequences. So again, important to note that. And also the different contrast agents. We all talk about gadolinium. I'm sure all of the neurosurgeons on this audience and everyone else is familiar with gadolinium. But realize different types of gadolinium have different inherent components, and some are going to be more sensitive than other components. So again, when you are monitoring the response, please work with your radiologist to make sure that the type of gadolinium that you're giving is also consistent as well. So because of this, I want to make sure that you really emphasize your technique. So my take-home messages is that imaging is important for the detection of brain metastases. We have to be familiar with the characteristics of different types of brain metastases and not confuse these with various mimics. Please, please, please make sure that your imaging technique is optimized and consistent for post-treatment images. Again, something that we don't emphasize enough. And then there is an evolving role for various biological and physiological techniques, such as spectroscopy and perfusion, and sometimes ADC as well for treatment monitoring. So thank you very much for the privilege and the honor of being here. And if it's okay, I'm happy to take any questions now before I have to sign off for my next presentation.
Thank you. Thank you, Dr. Mukherji, for giving one of the best lectures I've heard on metastasis. There are a few questions here on this Dr. Harsh Pares from India. He has asked, how do you differentiate a multicentric GBM from metastasis?
Right. So that's a great question. So again, the multi-sector GBM, this is what I would suggest, is that the multicentric GBMs tend to, at least in my experience, some tend to be necrotic, some tend to be solid. And part of it is the ability to look at the geographic distributions of the T2 and flare signal abnormality. So what I mean by multicentric GBMs is that oftentimes not all of those components have areas of enhancement, whereas the metastases will have increased flare in T2 signal surrounding the enhancing component. So in general, metastases will have the enhancing component with the surrounding vasogenic edema, whereas the multicentric gliomas, there will be a component that enhances, but sometimes there's flare in T2 signal that doesn't enhance. So when I see this inconsistent or heterogeneous pattern, that leads me more towards multicentric glioma versus metastases.
Thank you, Dr. Mukherji. Do any of the other speakers have any question? Dr. Dwaraka? If they don't have, I have a question. Can you please repeat? What I understood is when you do a serial scans, it's important to do with the same Tesla to evaluate the progression or reduction of resolution of disease. But you stress something on the gadolinium. Can you please repeat it?
Yeah, can I just share that slide? Thanks for mentioning that, because it is something that is just that I don't believe is underemphasized. So the premise of this is that anywhere from 10 to 40% of patients will have metastases. There are different ways that we detect metastases. There are different factors that are integrated into the most accurate detection of metastases. Part of this is sequences. So the lower your field strength is, so many of you may have less than 1 Tesla, 1.5 Tesla. The lower the field strength is, the less likely you are to detect lesions. The second thing is that the thinner your sections are, the more likelihood you are going to detect lesions. So make sure that your follow-ups are using on the same field strength and then also the same slice thickness. The other thing is that when we look at gadolinium, not all gadolinium agents are the same. There is something that's referred to as T1 relaxivity, which basically determines the brightness of gadolinium that we see once we take these images with MR. So these gadolinium agents can be linear or they can be macrocyclic. And in general, some of the linear agents have a little bit better relaxivity. They're a little bit brighter, but the macrocyclic agents tend to be safer. They tend to be associated with less side effects. And we went through something called NSF, nephrogenic systemic fibrosis. These compounds, the macrocyclic compounds, tend to be much safer when it comes to this. But my point is that when you are doing your follow-ups, just try to make sure, and they're probably doing this already, but try to make sure the same contrast is used. Practical aspect occurs is that if you have patients that are getting their follow-up imaging studies at different sites, it's possible they could be using different field strengths, they could be using different types of sequences, and they could be using different types of gadolinium. So when you are doing your monitoring, that's when this large variability comes up that may not give you an true accuracy to determine whether or not your treatment has been effective or not.
So it boils down that for follow-up, it's better to do at the same center so that consistency is there in the technique and the type of gadolinium they use.
That would be my opinion.
Yeah. The two more questions. Yes.
So Mukherji, that was a nice talk. So when we're doing radiosurgery, I mean, the different MRI sequences have different the error margins, for example, 3 Tesla and 7 Tesla, even though they show more lesions, they tend to have a more distortion than compared to 1.5 Tesla. So how does your center go about neutralizing this when you're using these high density images for high Tesla images for planning?
Right. Yeah, thanks for the question. I actually have a joint appointment in radiation oncology too, so it's nice that to see another radiation oncologist on the phone, on the member. So I can try to answer this briefly, is that in general, 7 Tesla has not really made it in prime time yet. Unfortunately, again, I trained in the last century, and I remember when 3 Tesla happened. It took us about 10 years to really become familiar with 3 Tesla. A lot of it is to better coil technology, et cetera. So as far as 7 Tesla is concerned, I probably wouldn't advocate 7 Tesla right now, especially from the distortion artifacts at the skull base. In general, 3 Tesla, if you are using the proper coils and you are using the proper sequences, in general, we don't see nearly as much distortion with 3 Tesla. Because this is a global audience, if you had to default to something, I would probably default to the magnet that's more consistent and then use some type of stealth or 3D sequences to do your acquisition. But I think in general, with 3 Tesla now, it is mainstream. And in general, I don't nearly see as much distortion artifacts in the brain from 3 Tesla. Now, the spine is different. I'm still a little bit leery about looking at spinal metastases on 3 Tesla, but I think the brain metastases, I'm pretty comfortable with the quality and the consistency of the imaging.
Yeah, you have 2 more questions, then we go to the next talk. How do you differentiate sarcoidosis from acute MS? And the other question is, how do you differentiate the edema between GBM and a metastasis?
Sure. A sarcoid versus multiple sclerosis, in general, sarcoid tends to be more linear and a little bit more solid. And for a patient to initially present with intracranial sarcoid extension without having systemic disease is pretty rare. So, and also sarcoid tends to not have the ring enhancement, and it also tends not to occur periventricular. Sarcoid tends to be more leptomeningeal, periventricular, and sometimes it can extend along the perivascular spaces involved in the deep brainstem, as opposed to the perivenular spaces that we kind of lovingly refer to as Dawson's fingers. So that's how I differentiate between those two. And then, I'm sorry, what was the second question? I apologize.
Second, the edema, how do you differentiate the edema in GBM and metastasis? Is there a difference?
So that's a great question. Let me mention one thing, and this is somewhat controversial, but sometimes what happens is it's physically impossible for us to differentiate small GBMs, solitary GBMs from metastases. It's very, very hard because the perfusion doesn't help and the spectroscopy doesn't help when we place it on the solid component. So my feeling about GBMs, and again, it's just my opinion versus metastases, is that GBM is truly a systemic disease. And I know there have been numerous studies that have been done that have identified that the edema surrounding GBMs also contain elevated levels of choline. So one way to go about this is that you could potentially perform MR spectroscopy and place it on the edema surrounding the GBM. And if you see elevated choline in that surrounding pure vasogenic edema, that's more suggestive of GBM. Whereas if you place that edema surrounding the metastases tend to be more confined and there's no choline. Similarly, there have been studies that have been done with perfusion suggesting that the edema surrounding GBMs have elevated perfusion. Again, I don't know if that's enough to really change your treatment, but I just wanted to let you know that these are some ways to potentially use biologic/physiological imaging to help us separate GBMs from metastases and those images that have overlapping features.
Yeah, thank you, Dr. Suresh.